All right. Hello, everyone, and welcome back. We are doing surgery today, and this is the second video that we're going to do, or the second segment or a study session. We have done the first one and we ended with the diffuse axonal injury. And now we are starting with the elevated intracranial pressure. As a reminder, in diffuse axonal injury, this is going to be on page 315 if you want to open your book on that page. We said that diffuse axonal injury is a diffuse injury that results from acceleration, deceleration injuries to the head. The patient will be deeply unconscious in that case. The prognosis is actually terrible, and the surgery cannot really do anything. Therapy is just directed at preventing further injury from increased intracranial pressure. All right. So we said intracranial pressure and increased intracranial pressure. So what's up with that? Let's talk. So elevated intracranial pressure, there will be a classic history which proceeds as follows. First, briefly depressed consciousness after head trauma. Second is going to be improvement. And third, there's going to be progressive drowsiness. Elevated intracranial pressure is a medical emergency here, and we should be able to pick it up and do anything to stop it. So, how are we going to diagnose that? What is the diagnostic testing? There's going to be gradual dilatation on one pupil, and a decreasing responsiveness to light is an important sign, as it indicates clot expansion on the ipsilateral hemisphere. Alright, so if we have a gradual dilatation of one pupil and a decreased responsiveness to light, we should think of elevated intracranial pressure. Whatever the cause is, we should think right away of elevated intracranial pressure. The second thing that we can see is that when we get a head CT, we look for any midline shift or any dilated ventricles that would indicate elevated intracranial pressure. Third, we do not think about performing a lumbar tap in anyone without first getting a head CT. That's very important. I remember in step 1, it said like 3 cases that we should get a head CT first before we do a lumbar puncture, and this is if we have any loss of consciousness, if we suspect that there is in any way increased intracranial pressure, like if we have epiledema, for example, or if we see the gradual dilatation in one pupil that we said and decreased responsiveness to light and so on. So that's when we do not do the lumbar puncture, because we would be afraid of herniation. If you perform a lumbar puncture on a person with increased intracranial pressure, you will herniate the brain, as I said, and kill the patient and fail the exam. So that's not really good. There is a vignette here that says basic signs correlate that we should note. It says that hyperventilation, it causes vasoconstriction and decreased blood volume in the brain, which will lower the intracranial pressure. So, again, hyperventilation will cause the vasoconstriction and decrease the blood volume to the brain and lower the intracranial pressure. So, all right, let's keep that in mind. Another vignette that says that steroids are good for cerebral edema secondary to tumors and abscesses, but they do not have any role in a head trauma. So if a patient has head trauma, we should not think of steroids like we do when we have tumors or abscesses. Okay, so steroids, no role in trauma. Okay, so we diagnose that patient. He has increased intracranial pressure. How are we going to manage this patient? Well, the first line measures should be the head elevation, hyperventilation, and we said why in just a while ago in that correlation with basic signs, and finally avoid the fluid overload. The second measures are first the mannitol. Use very cautiously. We should use mannitol very cautiously as it reduces cerebral perfusion, and sedation or hypothermia, and those lower the oxygen demand here. So those two things we can do. The first line we said, head elevation, hyperventilation, and avoid the fluid overload, and the second is to use mannitol and sedation. Another basic science correlate here. It says that mannitol is filtered by the glomeruli but not reabsorbed from the renal tubule. The result is decreased water and sodium reabsorption, which subsequently leads to decreased extracellular fluid volume. So it's an osmotic diuretic, just to sum it up. All right, it says here caution. Do not overdo the treatment for elevated intracranial pressure. If we lower the intracranial pressure and is not lowering the intracranial pressure is not the ultimate goal here. It's preserving the brain perfusion. That's more important. Systemic hypotension or excessive cerebral vasoconstriction may be counterproductive. So again, do not overdo it. Okay? All right. All right, so we are done with trauma here, and we can move on to general surgery. That's exciting. All right, let's start. What we're going to start with here is acute abdomen. Very important thing in surgery is acute abdomen here. We're going to talk about four things, or the four main causes of acute abdomen, and that's perforation, obstruction, inflammatory or infection, and ischemia. All right, so what is the most important question that we should ask ourselves when we are presented with a case of an acute abdomen? The most important question is, when are we going to operate, and when are we going to choose to treat medically? This is a very important question in surgery in general, but in acute abdomen here, surgery is the answer when we are presented with, first, if we are presented with peritonitis, excluding the primary peritonitis, if it is abdominal pain / tenderness plus signs of sepsis, if it is an acute intestinal ischemia, or if there is pneumoperitoneum. So again, if it is peritonitis, abdominal pain and tenderness plus signs of sepsis, acute intestinal ischemia, and pneumoperitoneum. In all of the above cases, we make sure pancreatitis is first ruled out. Okay? All right. Well, how about that primary peritonitis that we talked about? And primary peritonitis is a spontaneous inflammation in children with nephrosis, or an adult with ascites, and mild abdominal pain, even if there is fever and leukocytosis. So primary peritonitis, we do not do surgery in that case. Another side note here, it says that cholangitis is a gastrointestinal medical emergency, and intervention with an emergency ERCP is the treatment of choice. So cholangitis is different. Cholangitis here is a gastrointestinal medical emergency. It's not surgical, and we use an intervention with an emergency ERCP, endoscope, retrograde cholangiopancreatography, and it's the treatment of choice here. So when are we treating medically? Speaking of this, it's going to be a primary peritonitis, like we said before. It's going to be pancreatitis, cholangitis, urinary stones, and things that would mimic an acute abdomen, like a lower lobe pneumonia for in some cases, myocardial ischemia, pulmonary embolism, and finally something like ruptured ovarian cyst. So again, in medical cases of acute abdomen, it's going to be primary peritonitis, pancreatitis, cholangitis, urinary stones, and things that would mimic an acute abdomen, like lower lobe pneumonia. In this, we look for chest X-ray and see the infiltration. Myocardial ischemia, we do an EKG and see the changes. Pulmonary embolism, and we always suspect this in any immobilized patient or someone who has risk of DVT. And finally, if there is ruptured ovarian cysts. Okay, so the non-surgical causes of an acute abdomen would be myocardial infarction, acute pancreatitis, lower lobe pneumonia, pulmonary infarction, hepatitis, GERD, DKA, adrenal insufficiency, pyelonephritis, acute salpingitis, sickle cell crisis, and acute porphyria. Those are a lot of cases that we actually do not do any surgery in, and this is just a great list of causes here. I would actually argue that we should know when to do the surgery, and otherwise it's just medical treatment. That would make more sense here. And so on. Okay, but this is just my opinion here. A side note here says that we should be careful to differentiate between GERD and peptic ulcer perforation, which is a surgical emergency here. Okay? Okay. So now we're done with acute abdomen. Let's talk about perforation here. In perforations, we have different types. First, the gastrointestinal perforation. The question will describe acute abdominal pain that is sudden, severe, constant, and generalized. Okay, so sudden, severe, constant, and generalized. The pain is excruciating with any movement. It may be blunt in elderly patients, but in general, it's going to be excruciating pain with any movement. The most common causes of gastrointestinal perforations are first, diverticulitis. I actually thought it would be peptic ulcer, but first it's going to be diverticulitis that we should think about, especially in elderly patient with lower abdominal pain and fever. Then perforated peptic ulcers, that's going to be epigastric pain that classically wakes the patient at the night and possibly referred to the scapula. And finally, it's Crohn's disease. Okay? All right, so Crohn's disease would have the ulcers, and then it will perforate because it takes the whole wall, different than ulcerative colitis. All right, so again, diverticulitis, perforated peptic ulcer, and Crohn's disease. How are we going to diagnose that patient? Well, the diagnosis is with an erect chest X-ray. We will see a free air under the diaphragm or a falciform ligament or left lateral decubitus X-ray if the patient is too sick to stand up. The bottom line, we're going to see some free air either under the diaphragm or if we do the left lateral decubitus X-ray to see also the free air. How are we going to treat? Well, the treatment is as follows. First, we order nothing by mouth. That's very important. And IV fluids for hydration. The second is we're going to do IV antibiotics, such as metronidazole and Cipro. That's a good combo below the diaphragm. And the second generation cephalosporins like cefotitan or cefoxitin, we can use either piperacillin and tazobactam or ampicillin sulbactam, whatever those antibiotics are. And then finally, we perform the emergency surgery. Okay, so we order nothing by mouth, MPO, and IV fluids, we give IV antibiotics, and then emergency surgery. As a basic sign correlate here, metronidazole covalently binds to DNA. This disrupts its helical structure, inhibits bacterial nucleic acid synthesis, and results in bacterial death. So this is not bacteriostatic, it's bactericidal. It covalently binds to DNA. Metronidazole covalently binds to DNA and disrupts its helical structure, which inhibit the bacterial nucleic acid synthesis. All right. So we're done with the gastrointestinal perforation here. Let's go on to the esophageal perforation. The most common cause of esophageal perforation is the iatrogenic, so a doctor would be causing that. The case will describe that someone who's going to be having pain in the chest or the upper abdomen, dysphagia or odynophagia, which is pain or discomfort while swallowing, and subcutaneous emphysema shortly after endoscope. The classic presentation for perforation in that case would be after endoscope. So we should really think about perforation if any of these happen after an endoscope. All right, so esophageal perforation is a surgical emergency here. Gastrographene contrast ossiflogram is the first study of choice. We do not use barium here. So gastrographene contrast ossiflogram. Gastrographene ossiflogram. That's very important. All right. Okay. So far, so good. And it's a surgical emergency, like we said. So surgery is going to be done right away. After the perforation, we are talking about obstruction here. When can we suspect obstruction? We suspect obstruction in a patient who has severe colicky pain, absence of flatus or feces, high-pitched bowel sounds, nausea and vomiting, and the constant movement as the patient tries to find a position of comfort. So again, severe colicky pain, absence of flatus or feces, high-pitched bowel sounds, nausea and vomiting. And nausea and vomiting in patients, especially patients who are having these risk factors. So if somebody who is having prior surgery, we think of adhesions in that case. If an elderly patient with weight loss and anemia, or there is a melena as well, we think of a tumor. If there is history of recurrent lower abdominal pain, we think of diverticulitis in that case. History of hernia, which is just an obstructed hernia here. Sudden abdominal pain in elderly patients. We should not forget about volvulus here. That could actually be a case as well. All right. And finally, if we see a constant movement as the patient is trying to find a comfort spot. How we're going to diagnose that? We said we can do a CBC and lactate level. It's going to be elevated. Of course, this is not very specific. And then we can do a supine and erect abdominal X-ray. We look for dilated loops of bowel, absence of gas in the rectum, Bird's peak sign for volvulus, whatever the signs we can see in the abdominal X-ray, and then finally we can do a CT scan of the abdomen and pelvis with contrast. This is the most accurate test, so that can be the answer for the most accurate test in the exam, and it can at times show a transition point. The transition point is the location at which the obstruction has occurred. So we can see exactly where the obstruction is, and this can help us guide the treatment. We should note that in a patient with hernia, immediate surgery is the answer if the case describes fever, leukocytosis, constant pain, and signs of peritoneal irritation. Now, we should think of that it is a strangulated obstruction here. So that's just going to be an emergency that should be dealt with right away. All right, so how are we going to treat that patient in general with obstruction here? First, nothing by mouth, again, just like perforation, but we're going to add nasogastric suction and IV fluids. We should consider gastrografine contrast study until perforation has been ruled out. Then it depends on the case itself. So if we have a volvulus, we perform a proctosigmoidoscopy with the rigid instrument and trying to correct the volvulus here. We leave the rectal tube in place, perform sigmoid resection for recurrent cases. Okay, so we do the proctosigmoidoscopy with the rigid instrument. We leave the rectal tube in place, and we perform sigmoid resection if it is a recurrent case. How about an abdominal hernia? We said that in an abdominal hernia that shows with fever, leukocytosis, and constant pain, it should be surgery right away. But if it is just an abdominal hernia, we perform elective repair for all abdominal hernias except umbilical hernia in a patient of less than 2 years old and esophageal sliding hiatal hernia. That's a different story. And finally, in all other obstructions, we just do the emergency surgery right away. All right? Okay. There is a basic sign correlate that we should address here. It says that gastrografine is water soluble, which is not like barium here, which is caustic if it extravasate. That means that it will not do any harm if it extravasate, and that's a good thing. However, barium is not like that, so that's a problem. That's why we use gastrografine instead of barium in case we are suspecting perforation here. All right? Okay. Now, after perforation and obstruction, we would like to talk about inflammation. Inflammatory causes of acute abdomen would include our acute diverticulitis, acute pancreatitis, and appendicitis. The question, it's going to describe a gradual onset of constant abdominal pain. Okay? Gradual onset of constant abdominal pain that slowly builds up over several hours. Initially, it's ill-defined pain that eventually becomes localized as a sign of inflammation, and we should note that signs of peritoneal irritation are absent in pancreatitis, but it is present in diverticulitis and appendicitis. Okay? All right. Let's first talk about acute diverticulitis here. And acute diverticulitis is one of the very few inflammatory processes presenting with acute abdomen in the left lower quadrant. That's very pathognomonic, kind of. We look for a patient in the middle age or older with fever, leukocytosis, and peritoneal irritation, of course. And this is going to be in the lower quadrant with a palpable tender mass. In women, we should think of fallopian tube and ovaries as well. So we probably do an ultrasound in that case. But, however, we should suspect acute diverticulitis nonetheless. When we diagnose acute diverticulitis, we should not forget to order a urine pregnancy test. This is very important because it could be ectopic pregnancy at that time. So we should do that as well, along with the ultrasound. It says here that there is a basic sign correlate again. The common location for diverticulosis is the sigmoid colon here. This is because it has the smallest diameter and therefore the highest intraluminal pressure. Concurrently, the sigmoid has the highest degree of diverticulitis as well. So that just goes that way. So if we think of diverticulitis, the sigmoid colon should be the first one to think of. How are we going to diagnose that patient? Well, the most accurate test is a CT with contrast to look for abscess or free air. Fat stranding is common around the inflamed bowel. Okay, right. Well, how about colonoscopy here? It should be noted that colonoscopy is absolutely contraindicated in acute diverticulitis. This is for a very important thing here, is that it would raise the risk of perforation, which is really, really bad. So we should refrain from doing colonoscopy in a patient with acute diverticulitis. All right, so we diagnosed that patient with the CT scan that we talked about, with the contrast and so on, and now we need to treat. First, if there is no peritoneal signs, we just manage on an outpatient with antibiotics. It's going to be easy. If it is localized peritoneal signs or an abscess, we should admit the patient, NPO, IV fluids, IV antibiotics, and a CT-guided percutaneous drainage of the abscess. So again, no peritoneal signs. We don't do anything to the patient in the hospital. Send them home with antibiotics to be managed on outpatient. If there is localized peritoneal signs or an abscess or plus an abscess, we admit the patient, nothing per mouse, IV fluids, IV antibiotics, and we do a CT-guided percutaneous drainage of the abscess. Well, how about we have a patient who has generalized peritonitis or even perforation? Well, like we said before, we deal with it as a perforation, and in perforation we do emergency surgery. How about if we're having recurrent attacks of diverticulitis? Well, we do surgery, but this is not an emergency case here. It can be done as an elective surgery. All right? Okay, great. So now we're done with acute diverticulitis. Let's move to acute pancreatitis. When are we going to suspect a patient with acute pancreatitis? Well, first we should look for risk factors. That's very important here. It's going to be in the exam, and it's going to be in the stem of the question. If they mention somebody who has alcoholism, gallstones, if he's having specific medications like didanosine or pentamidine, flagyl, tetracycline, thiazides, furosemide, something like that. So some certain medications. If there is hypertriglyceridemia, specifically if it's really, really high, like 600 to 1,000 or something like that, trauma, of course, and post-ERCP. So those risk factors, we should suspect acute pancreatitis right away. In an alcoholic patient who develops acute upper abdominal pain or leaning to the back with nausea and vomiting, for example, that's going to be a classic case of acute pancreatitis right there. So when we diagnose acute pancreatitis, it could be in different forms. First, or the least, is the edematous type, and then we have the hemorrhagic type, and then we have the suppurative type, which is the abscess. Some people would argue about the pancreatic pseudocyst or chronic pancreatitis. Those are actually more of a complication. That's not an acute form. So if we see a pseudocyst or there is recurrence of the case, that's just chronic pancreatitis. It's a different thing. This is a late complication. But in an acute case, we will see the edematous type, the hemorrhagic type, or the suppurative type, which is the abscess. How are we going to diagnose that patient? The diagnose with serum or urinary amylase or lipase. There is going to be from 12 to 48 hours after the start, and the urinary from the 3rd to the 6th days. So amylase or lipase, we can do that as the first or the initial test, but we should wait 12 to 48 hours after the start of the symptoms. And for the urinary, it's going to be 3 to 6 days. And if we're not really certain, we can do a CT, and that's going to be the most accurate test. When we see a patient, we should look for warning signs that would indicate that there is hemorrhagic pancreatitis. That's actually fatal, and it's really important that we spot it. What we're going to look for. First, we're going to see lower hematocrit that continues to fall the day after presentation. We're going to see very high white blood cell count, even more than 18,000. We're going to see high glucose, high BUM, and we're going to see very low calcium. So again, low hematocrit, high white blood cell count, glucose and BUN, and very low calcium. That's when we suspect hemorrhagic pancreatitis. As a basic science correlate here, it says that pancreatitis can lead to lower calcium, but how? That's going to be due to the presence of insoluble calcium salts in the pancreas. The free fatty acids avidly chelate the salts, and that would result in calcium deposition in the retroperitoneum here. So that's just taking calcium from the serum and it's going to lower the calcium right away. Okay? All right. Okay, and we are going to now treat that patient. We diagnosed him with acute pancreatitis, and now it's time for the treatment. We're going to treat with, first, as always, nothing per mouse, nasogastric suction, and IV fluids. If there is complications, we're going to treat as they occur. First, if it's an abscess, this often appears 10 days after the onset of the persistent fever and white blood cell count and so on. We do surgical drainage, of course. If it's a pseudocyst, that's just going to be 5 weeks after the initial symptoms, and in that case, when a collection of pancreatic juice is going to cause anorexia, pain, and palpable mess, and so on. If it's painless, we don't do anything. But if it is painful and it is more than 6 centimeters and it's for more than 6 weeks, we do surgical internal drainage or endoscopic drainage. If it is infected, we do a percutaneous external drainage, and so on is performed. Finally, if there is chronic damage, which will cause diabetes and steatorrhea and so on, we treat with insulin and pancreatic enzymes and so on. Okay? All right. A slide note says that about amylase and lipase here. Which one is sensitive or more sensitive, and which is more specific? It says that amylase here is sensitive. So if we have amylase, that just most likely, if there is a problem with the pancreas, most likely amylase will be elevated. And lipase is very specific. So if we have lipase that is high, that means that for sure we do have pancreatitis here. So if we want to make sure, we do lipase. If we want to detect or screen, we do amylase. Again here, for the treatment, we said that nothing per mouse, nasogastric suction, and IV fluids. If it's an abscess, just surgical drainage. Pseudo-abscess, it depends. If it's painless, if it's painful. If it is painless, we don't do anything. If it's painful and more than 6 centimeters and for more than 6 weeks, we do surgical internal drainage or endoscopic drainage to drain inside the body. If it's infected, we do external percutaneous drainage. And in chronic damage, we just replace what is lost. So we give insulin and we give pancreatic enzyme supplements. All right, and that's more than even 25 minutes here. We're going to take a short break for 5 minutes, and then we will be back with acute appendicitis. All right, see you guys later. Bye.